Hi folks, you're with Tassus today at your Pushback channel, and thank you for joining this live stream. In this essay, I'd like to talk about health coverage, universal health coverage. Now, if we look at, say, in the United States, there was Obamacare, and then before that, Hillary tried to get universal health coverage going in the US, and the US stayed, well, to a large extent at least, private. Although there's a lot of pro bono type services that are given to people in emergency departments, the illegal aliens coming in, for example. Now, there are other countries like Canada or Australia or Britain that have what's called a universal health scheme. So everyone, in theory at least, is covered, or their health is covered by the state, and health services delivered by the state. Now, there are still a lot of people in these countries, Australia included, that take out private health insurance as like a top-up. So that gives you access to the better quality hospitals and better quality doctors and specialists and so on. Not that you can't get them in the government hospitals, but it's like a lottery ticket. You just don't know. So you can end up going into hospital for an urgent operation, and you've got someone who maybe's just come out of medical school, and maybe they're an affirmative action hire, and they didn't really do that well at the medical school, so they could be the one operating on you. Whereas if you've got the private health insurance in Australia, you can say, well, I want to go to that private hospital that's got a good reputation, and I want this or that specialist doctor to do a heart operation or I don't know, brain surgery or whatever it might be. So that's how that's the situation. The overall sort of situation in terms of how the private and the public health system mix in Australia. There are still private patients, but everyone's covered under the public system. Now, rationing occurs. Well, one of the big things I've noticed, say, in Senate hearing committees in the United States or congressional committees, is they say, well, in universal health care, we can't deliver the same services to everybody, so we have to ration services, and therefore universal health care means rationing, and which is true, by the way, and I'll come back to that. But the reality is that when you have to pay top dollar for medical care, that not everyone can afford that. Very few can afford it. So rationing occurs anyway, based on who has the most money or who can afford a procedure. Now, I had a relative that recently, a couple of years ago, I guess now, went into hospital, and the operation, which wasn't really a life and death gig, you wouldn't think, but it cost $15,000 on top of all the other medical expenses she had to meet. She couldn't afford it, but the doctors viewed that her two things. They viewed that her case was urgent enough, and secondly, that if like as an urgent, if they didn't give it to her, that her health would deteriorate further, and secondly, that once the procedure was done, that her overall health was quite good, therefore she would recover and could live. So the doctors or the medical staff were making two value judgments, and this is where the rationing comes in. They can say, well, look, sure, you do need that procedure, Billy Bob the patient, you do need that procedure, but we've got other more urgent cases in front of you. We think you can live a bit longer without the procedure, so we're going to put you further down the queue while we do these other people who have a more urgent situation. In other things, some people we know, the lady needed, I think it was a hip and a knee replacement, but the doctors said, well, look, you weigh nearly 300 pounds. Really, you've got to lose a lot of weight, because if we do the procedure, given how much weight you've got on you, you're going to just be back to square one in 6 months. So there's no point in doing the procedure unless you're going to really get benefit out of it. So go and lose the weight first, and then come back to us. Now, she doesn't lose the weight, and makes a half-assed effort, but doesn't lose the weight. But then it gets to such a critical stage that her very life is in danger, and then they will do the procedure, even though they think it's very unlikely she's going to materially benefit from it, because the case is so urgent that they will do it. So this is the sort of the cross-reference, the grid reference, if you like, of rationing. So someone who comes in and they're not sort of going to die tomorrow, but it's believed that the procedure will be wasted on them because their overall health is terrible, then they may not get operated on at all, and then it becomes a sort of a de facto form of euthanasia, and that happens a lot too in universal health schemes. So there are finite resources, but an infinite demand, and so because of that, they have to do this rationing. And whether rationing is done fairly or reasonably or discriminate, is discriminatory to certain, that's a matter for discussion. For example, there's a guy whose overall health was quite poor, but he's got four children at school age, so he was given a priority because his breadwinning sort of capacity was needed for the family, so he was viewed as a priority because of that. So there are various things that now in the United States or anywhere where there's no universal health scheme, the rationing still goes on. But as I mentioned earlier, it's because not everyone can afford the procedure. So if you go in, the doctor says, well, it's going to cost you $20,000. And by the way, we want some money up front, and we want to know you've got the capacity to pay. Show us your bank statements, for example. Well, we're not going to operate until we're satisfied or confident you can pay us. So that becomes a form of rationing. Billy Bob can pay, but Jimmy Jack can't. So Billy Bob gets the service and the medical procedure, and Jimmy Jack doesn't because he can't afford to pay for it. So rationing occurs on both sides, but for different reasons, of course. Now, coming back to the relative who needed a medical procedure, it cost about $15,000, which, given all the other expenses she had to meet, she couldn't afford. And so, but because she was, it was so enduring, her life was threatened, so they believed. They did the procedure anyway. Now, the government pays the hospital a proportion of what they say that procedure is worth. Now, the government says it's worth $4,000, so they still get paid for it. But a private patient would pay $15,000. So as far as the hospital's concerned, they've lost $11,000. So I was kind of interested in how they would go about doing this. So again, it wasn't a huge operation. It was I suppose, keyhole sort of surgery type procedure, that type of thing. They did the procedure, and it took an hour and a half, I guess, something in that region. But they'd been on shift since 11 o'clock the night before, and they didn't do her. She was the last patient in the batch, the only one that was on a government-funded procedure. All the others were private, so they left it at last. Then the qualified, the top qualified specialists went off into a side room, and then they were there for consultation if needed. And then the trainees were given the job of doing this procedure, and the attitude was very much like, "Hey, you're lucky we're doing this at all." Given the aftermath of that procedure, I think that the trainees came dangerously close to fucking it up. But that's what you get when you're on a public health scheme. You don't get a choice of the doctor or the specialist. And on top of that, all these people have been working more than 12 hours already in pretty intense work. They've been working for over 12 hours, and they're then doing another procedure. Trainees who are tired, exhausted after the long shift and everything, they're doing the work. And by that stage, the ward orderlies have gone. So, after this procedure, she's got to pick herself up off the operating table and put herself onto the trolley that they wheel you around. That's a public health scheme for you there. They don't want to pay overtime to the ward orderlies, so they've already gone. And some other things I noticed in there where clearly there's no silver service going on there. It's corners are being cut and so on. But anyway, that was she's still alive and around today. So, but this sort of rationing, not only in the do you get the procedure at all, but rationing in the sense that you get the junior trainee doctor to do the work. That's quite a scary sort of aspect of public health. Now, there's another sort of layer of this when you go and just see your local doctor. It's I don't know what they call them in America, but they're called general practitioners in Australia and England and I assume Canada. But so you just go and see your local doctor now. A lot of the medical centres where these doctors work have been bought out by big investment firms, and that they get paid a certain rate. So they get, for example, they get paid $20 for every patient they see. Now, if you're seeing a patient for something easy like a repeat of a prescription or something, where they're in there for 2 minutes and out again, $20 is fine. But if you're seeing a patient for the first time, or it's a complicated patient, maybe a patient you can only communicate with them through interpreters, which is more and more the case these days, then the consultation can last for an hour. But all the people that can't speak English, more difficult cases, are all public, on the public purse. So if you can screw another patient, a more sophisticated patient, shall we say, if you can screw them to pay extra, then that's the tactic. So what's happening certainly these days, and by my experience, is Billy Bob calls the doctor and I need to come and get a prescription renewal, for example, and so, or maybe they've done a blood test or something like that, and but they've got a policy where, well, no, we can't give you the blood test, we can't tell you what's in it. You can only get that information if you come in and have a consultation with the doctor. So, okay, Billy Bob says, right. And they say, well, is it urgent? Do you need to see a doctor in the next week? Oh, yeah. Oh, okay, well, you won't be on the public purse there. If you want to see a doctor in the next week or two, you'll have to pay an extra $50 on top of the money we get from the government. And Billy Bob might say, well, hey, I only want a prescription renewal. I'm only going to be in there for 10 seconds. Don't care. If you want anything to happen quickly, you've got to pay. And if they think you've got theoretically the capacity to pay, then they're going to come after you for the money that they can't get out of the illegal aliens and alleged refugees that come in. So it's morphing in that sense, particularly given that big money has moved into the medical centre, investing in medical centres, and they're there to extract wealth. They're not there to provide medical services. So that's a big issue there. Now, if you're prepared to wait, say, all right, then, well, if you want to go on the public health system to see the doctor, it's going to be 4 weeks, 4 weeks waiting list, because the amount of doctors that are prepared, or the amount of doctors they've allocated to public health, is shrinking. It used to be, you go to certain medical centres and they were all on the public, the public health system. But now, out of 10 doctors, maybe 2 are in the public health thing. And again, most of the people who are wanting to see them are difficult, long consultation time patients. So they're trying to push as many patients as possible into paying an extra top-up fee, and but for no benefit. You don't get the benefit, and if you're that sick that you need to see a doctor straight away, they'll try and use that to extract another 20, 30, 40, $50 out of you. So the public health scheme, as we know it, is changing quite substantially, not only from the rationing perspective, but the far lower quality of general practitioner, and then the financial, the big big money guys moving into buying the medical centres and then using them to extract as much money as they can out of the patients they think can pay. Anyway, I hope that overview gives you a better understanding of what's going on and the difference between the two. You've been with Tastus today, your Pushback channel. Thank you for listening.